Okay, well, my name is Eric, again. I'm going to be talking about our experience with medical ethics and challenges we had in having our super premature son, Gabriel, who was born at Swedish Medical Center in 2012. We'll get into that in a few minutes. Just to tell you a little bit about myself, I'm also writing a book about our experiences, a medical memoir with major faith components to it, and so that's one of the reasons I go on these speaking opportunities. My wife is presently working today at her veterinary hospital in Kent. She's also studying to earn her veterinary technician certificate. She's in her last month of classes there. And so when you're a vet tech, you're sort of a combination of a nurse and a pharmacist for animals. And so I imagine she's going through many of the same topics, and you know, they did do some ethical work there as well. So yep, there's the title screen. That's the current name of the book. It has gone through about 4 different names. And believe you me, if you're going on to quite an adventurous life as nurses, and you're going to see some wonderful stories, and try to keep them in your head, and then when it's time to write the story, boy, that's going to be hard too, so get help. So the current title, Too Young to Save, Our Preemie, My Weakness, and God's Strength. I'll start you off with a video of... We've got him off the dopamine now.
That's what Mary was saying.
Yes, and that means his heart is keeping his blood pressure up at the right level by itself.
Okay.
And his blood is a little on the acidic side, so giving him sodium bicarbonate for that.
Already he's getting baking soda, huh?
Yeah, and he's been getting a lot of transfusions lately, just because, well, his body only has about 3 tablespoons of blood in it.
Is that all?
Yeah.
3 tablespoons, wow.
Yeah. So that video was taken when he was born at 22 weeks and 6 days of gestation. That video was taken when he was about a day and a half old. The voices there are mine and my father's, and we're taking the video for my grandmother, who wasn't going to come to the hospital. It was too much, for her to get out of the assisted living facility. And as an aside, my grandmother is actually a graduate of SPU. She got her Master's of Education here back in 1950, or maybe it was 1952. And when she applied, they sent questionnaires around to her neighbors asking if she ever engaged in dancing or drinking.
There's a joke about that. Remind me later and I'll tell it to you.
Okay. So, but back to a more serious aspect of this. Getting to the point where we had Gabriel in the incubator and receiving all that care through all those tubes was quite a challenge, just to convince the doctor to do it. And he said that he didn't recommend that we treat him, just because the results are so bad. And this is the quote that he used, which has stuck in our minds ever since then. Miri had gone into preterm labor at 21 weeks and 4 days, and we'd gotten to Swedish at that time, which is a level 3. Has a level 3 NICU, so they can receive a baby that is the most premature babies there are. They can deal with them there, but they were telling us, well, 21 weeks and 4 days or 21 weeks and 5 days, it's way too early. There's no way we can do this. Do you want to abort? And we said no. Do you want to just let the pregnancy go forward? We said no. And then they said, well, we can also give you these awful drugs and stop the pregnancy that way with one of the drug, one was indomethacin, which is a really strong cousin of ibuprofen, And then the other was magnesium sulfate, which will make you feel like the backs of your eyes are on fire. And so these were not nice drugs, but Mary said, yes, let's go. We're going to try to save this baby. And so she made it to 22 weeks and 6 days, and her water broke at 6 p.m. that day. And the doctor came and saw us at 7 p.m. to talk about what we were going to do next. And he was saying, well, if you make it to midnight, well, it's possible, but we don't really want. He didn't really want to do it. And so this is the quote. If you come give birth after midnight, I'll be the one who comes, but my heart won't be fully in it. But we did. He was born at 11:20 p.m. We were able to talk that doctor into providing treatment, and that's where we started. So, my purposes in giving talks like this to groups of nurses, to priests, to chaplains, to parents. Gosh, this is going to be a little. I'm going to stand up for her.
Yeah, feel free to stand, or if you want to move your chair somewhere else more convenient, or whatever you want to do.
Okay, so I can see a little bit of it. There we go. So, to suggest better ways of navigating this dilemma, to encourage doctors to seek out motivations, not just wishes. And actually, my last talk back in a few months ago was for a group of priests, so that's why that last bullet item is on there. But I don't know if any of you go into the chaplaincy or do preaching on the weekends. Maybe that will be useful for you. So this also, the quote earlier raised the obvious question of, can the doctor do that, to say that he wouldn't provide care? And after we got out of the hospital and I did some searching around to try to process what all happened to us, I found that in fact his recommendation was in accordance with national standards at that time. And these are resuscitation guidelines from 2010 that say resuscitation is not indicated for, and it gives a list of reasons, one of which is gestational age of less than 23 weeks. Well, then why would he say that? And indeed he was correct that the danger presented by our son's birth was pretty great to him. This is a study of survival rates from Japan, and in Japan survival rates are a bit higher, and we'll get into that later. But in the 22nd week, 63% of the babies died, and 73% either died or had profound neurodevelopmental impairment. And as you go forward through the weeks, you find that you get to the 23rd week, you get 35% dying, and eventually down to the 25th week where you have only 14% dying. And so what you have is this gray area where it's permissible to not provide a treatment, and at some points doctors would say it is required that you not provide treatment, and this caused an ethical dilemma, a conflict between us and the doctor. Doctors use the concept of futility to approach this question, which is defined as care unlikely to benefit the patient or to provide poor quality of benefit. And I think the latter one of those is kind of a confusing term, but it is very relevant. And it's that the doctor said, well, if he even does survive, he's going to have such great disability, you're not going to be happy with him at all. And it may even be to the suffering that he's enduring may be a fate worse than death. The dilemma presented kind of a strange time crunch for us, because at the time when we were discussing this, the baby really was just fine. We'd had ultrasounds done and everything in there appeared to be just fine. It was the preterm labor was the problem, and we really didn't have any idea why this was happening. And so with the birth of a preemie, you make this decision to not provide treatment. Well, it's on a patient who's just doing just fine. It's what's going to happen in the future that makes you make the decision not to provide treatment. What this opens up is kind of a window of death in which you can make a decision that doesn't actively kill somebody, but it basically has the same effect of that you know the person is going to die, and it's because of a decision that you've made. And we thought that this is similar to the decision that many parents will make when Down syndrome is detected in the womb. And in this country, 67% of Down syndrome babies are aborted. We felt like this is what we were being asked to do, except it was just at birth as opposed to, at 16 weeks. So how do you view this decision that you may make to walk away or to not provide treatment? Do you look at it as walking away from a potentially disabled child? Do you look at it as taking advantage of the disabled at their weakest moment, or conversely reducing the suffering of someone who is likely to die? And I have read books by other preemie parents in which the doctor looked at a baby in this gray zone and said, we're going to resuscitate this child no matter what, and we're not going to listen to you when you're asking for a compassionate withholding of care. And that introduced a whole different series of ethical problems. We looked at this from the perspective of autonomy of the patient versus beneficence, and to try to compare this to an adult situation, you think about it telling a breast cancer patient that they have a 30% chance of survival, but you say, well, it's just not worth it. We're not going to provide treatment. Could you do such a thing? I don't think so. Or conversely, if you tell adult patients you have a 30% chance of survival, 5 months of very uncomfortable treatment, disability is likely with survival, will they all say yes to that? Do you force them to take that treatment? We were also given antenatal counseling, at which a different doctor presented us with a list of statistics and outcomes. They were somewhat helpful to us, and they used these categories of unimpaired, moderate to severe neurodevelopmental impairment, severe to profound neurodevelopmental impairment, and death. And it took me a while to realize that profound was actually worse than severe. This is, the first time I'd encountered it this way. They weren't the most meaningful categories of statistics to us. What they kind of sound like to when you're in crisis, what they sound like is, dead, almost dead, and comatose. As years went on, we realized what moderate to severe actually means, and if a moderate neurodevelopmental impairment is defined as something like a 75 or less on the Bailey infant scales or child development scales, and that can be a child who's simply 6 months behind his peers, but is going to catch up, and that's moderate neurodevelopmental impairment. And it really just disturbed us that they're using that as a potential reason to let a child go. When Gabriel was 2, we wrote a letter to the ethics committee at Swedish Medical Center saying how we'd been upset by this and how we didn't feel this was a good way to be treating us or to be treating preemie parents. And there had been some changes made in the time since we'd been there. One is that the 23 and 0 day line in the sand that they were using then had gone. That made us feel a lot better. They said sorry that you felt pushed, but there are some families when you interview them, they're looking for any reason they can to let go. So they can't be pushing families to do something else. I suggested that they should try starting the talk with something like "Your child is welcome in our nursery," which I thought was an objective kind of a statement that they could make. Without biasing it one way or the other. They said, well, what we think happened that went wrong was that the decision arrived at between the parents and the doctor should be fully supported from that point going forward, and in this case it was not. And they apologized for that, which meant a huge deal to us. I suggested that they I suggested they provide local statistics rather than just the gloomy national statistics. And those national statistics they gave us were about 15 years old, so they had worse outcomes because it's such new medical technology. And the doctor then responded, well, we could say we've had a 100% success rate at 22 weekers. And I had to smack my forehead and say, okay, I see your point. Gabriel's the only one. 22 weekers are really rare. And then we also talked about that birth to 3 medical professionals, people therapists who deal with children who have had birth injuries or super preemies should attend the counseling to give an idea of what kinds of qualitative lives these children lead, to give parents an idea of what they're getting into. Also around the same time, the American Academy of Pediatrics released a new set of resuscitation guidelines. So the first set I showed you was from 2010. This set is from 2015. Which includes saying that the gray zone is between 22 and 24 weeks, as opposed to what it used to be was 23 and 25 weeks. We were quite happy that this had been done, and it gave us some hope that maybe more children would be resuscitated. In Japan, since the 1990s, they've been resuscitating children routinely in the 22nd week. And that's part of the impetus for why this change has been made, is to realize that the kids are surviving in the 30 to 40% range in Japan, as opposed to the ghastly 6% range they were quoting over here. So as to say that if you give the kids a chance, they can survive, even if you have this gloomy opinion. We also wrote an editorial to Pediatrics, the Journal of Pediatrics, and we were very impressed at how they actually took us seriously. I thought they were going to say, "Oh, you're just an emotional parent. You're not going to. You want everything to be done, but you don't understand what's really going on." And so, as I'm sure as you've read, we said that the ability statistics are okay, but you also need to talk about quality of life. You need to seek out the motivations of parents rather than just asking them how do you think about this? Say, what in your mind might be some reasons for this decision. In our case, we had some of our attitudes about what makes life worthwhile is that we were quite willing to accept a disabled child, and we believe that life glorifies God, even if it exists for just a few minutes, even if it exists in a disabled form, even if there's suffering with it. We are willing to take on that responsibility and that risk. There are other parents who are not, and medical professionals need to be respectful of those parents who want to let their children go, but ask those questions about why do you feel this way? I suggested asking which is better, a short goodbye or a strong possibility of one in a week. I get the impression our doctor was trying to protect us from the harder emotions of having a child survive for a week or two and then die. I appreciate why he was saying that, but at the same time, we were willing to take on the possibility of that kind of heartbreak. And I also suggested talking about the baby by name, just to make it clear that this is a person. This is a member of the family. This is someone who can come into the world, who can come into the nursery. Okay, now I have another video. You're a very smart boy.
No, I'm not. I am a mad boy.
What does that mean?
Hey, I am a mad boy.
Oh, I don't think you're a mad boy. You look like a happy boy to me.
No, I am not happy boy. I am a mad boy.
So, did he convince you? He's 3.5 in this video. I just think it's delightful, just the kind of toddler humor that you're seeing here, and the wordplay. It's preschooler humor, I should say. The wordplay, the emotions, the funny faces. So, just to tell you a little bit about I got past the ethical dilemma component here. To get on to the NICU stay, this picture was taken when Gabriel was a week old, and so he's got the ventilator tube down his throat to provide so that they can control his breathing that way. And those are Miri's hands holding him there. We came to call him the protected contact baby because my wife at that time was a zookeeper. Now she's a veterinary technician. And protected contact is a practice within zookeeping in which the animal is kept from being able to interact completely with the zookeepers. In this case, this is a picture from the Oakland Zoo. That's not Miri there, but this is an elephant getting his feet cleaned and trimmed, and you see that bar there in front of between the keeper and the elephant. That's there to keep the keeper from getting trampled, and it also protects the animal, helps the animal stay a little bit wild, and also reduces the need for painful punishment methods. And so that's how we felt our baby was during this time, and it was very emotionally difficult for us to be that separated from the child, and also to get there and to be told, well, you're not supposed to cuddle him. It's supposed to be like the womb, so we keep it as quiet as possible. Don't touch him. Don't this. Don't that. They did teach us how to change diapers during the CARES times, which would happen once every 4 hours, and that would be our little little moment of interaction. But at the same time, it's a difficult time, and nurses were helpful with us through that time period. So we had a 5-month NICU stay. And here are the names of the various conditions that he had. 5 weeks on the ventilator gave him bronchopulmonary dysplasia, irritated, which is a condition that only exists in the NICU. He had patent ductus arteriosus, which we were able to correct, or the doctors were able to correct with indomethacin, which was a lot better than open heart surgery. Congenital adrenal hyperplasia, which was probably a false positive. That was a lovely, scary moment when the doctor said, does this run in the family? Does somebody have a baby who's suddenly died of dehydration at 3 weeks old? And we're like, no. But you get a lot of false positives just because a preemie's chemicals are just so off that you start testing positive for things like that. He had one infection that went septic. It was a urinary tract infection. He got around 32 or 33 weeks, and that delayed him from being able to learn to suck from a bottle, and then he never learned to suck from a bottle, really. So he was also diagnosed with stage 2 retinopathy of prematurity, but he was able to self-correct from that. And he did not feed enough on his own, and we ended up leaving the hospital with a gastric tube. And surgery at the end to do that. The two things he didn't get, however, these are the NICU diseases that are the real awful ones. It's necrotizing enterocolitis and brain bleeds. Here's a picture of him at 5 weeks old. This is the mask he's wearing. Looks far more menacing than the tube, but it was a step up. It was far more gentle. It's the CPAP, which is a big deal towards, was a big, big step for him. At 3 months old, he's starting to look a little bit more like a baby, and we gave him a bath in this little plastic bin that we still have in the house. They let us take it home, and it's about that.
So when you think about it, with corrected age of preemies, he's not even full term here, right?
That's
he's
right.
12 weeks plus. He was born at
22 weeks.
22, so 12 plus 22.
Yeah.
He's still 6 weeks shy of full term.
Yeah. And that thing he's wearing there is the Vapotherm, which provides a little bit of pressure to help keep his airway open and provide oxygen. That's at term day. We actually caught him mid-smile. And I believe that is another step down of oxygen support. So it's just providing a little bit of oxygen, but it is not providing any particular pressure. Some things that nurses did to help us out. One is they saved holding tasks for when they knew we were coming. For example, when he was 2 weeks old, they changed out his incubator with a different incubator so they could clean the old one. And so they knew they'd have to take him out of the incubator and hold him for 10 minutes, so they saved that for us. And that was the very first time we got to hold him for any meaningful length of time. Right after Gabriel was born, they let me baptize him with sterile water, and then they had him hooked up to the mobile incubator and all that stuff, and they let Miri hold him for about 10 seconds and then stuck him in the incubator and took him upstairs, and that was the only time she'd held him at that point. So she got to hold him for 10 minutes, not 10 seconds, which made a huge deal. And so they saved that for us. It also meant a lot that when they'd say things like he's acting his age, when he would do something awful with his breathing, like forget to breathe, or his...
Do you know what this is on your face?
What?
That was something else to help you breathe. It was really hard for you to breathe, so they had to give you a little bit of help.
But after 5 weeks, he was off the
Ventilator.
Want to crap. Crap.
Well, yeah, but
That particular
CPAP.
word is CPAP or CPAP.